My name is David Kooby. I'm a surgical oncologist at Emory University School of Medicine. I specialize in complex gastrointestinal surgery and focus on upper gastrointestinal tract. I'm full professor of surgery. I am the vice chief of staff at the Emory St. Joseph's location and the surgical lead for the northern arc in the Emory system. Pancreatic neuroendocrine tumors are an unusual group of diseases. You have patients that have aggressive disease that will grow very quickly, better known as a small cell carcinoma of the pancreas. And then you have other patients who will present with really small tumors within the pancreas that maybe now, based on later data, most recent data, can actually be observed and not operated on. So the question really comes up, who are the right patients for surgery for pancreatic neuroendocrine tumors? And what approaches do we have available at our disposal and what are the potential outcomes for these patients? So the appropriate patient for resection for a pancreatic neuroendocrine tumor, first, it has to be imaged appropriately so you know the extent of disease. And then it is quite useful in many circumstances to get a biopsy up front to know that you're operating on the right disease and to decide if there are other options or other treatments or if the tumor can be observed in the first place. Let's start with a patient with a small tumor. So if somebody shows up with a 1 centimeter hypervascular mass in the pancreas, be it in the head or the tail of the pancreas, we've got to go through a few things. Number one, got to get to know the patient a little bit so they understand about the disease. Most patients who are told, hey, you have a tumor and we're going to watch it and not operate on it, they'll get pretty anxious. So having some information, maybe a biopsy done endoscopically, which is low risk and pretty high yield if done by somebody with good experience, can give them some information, arm them so that they know emotionally that it's okay to watch the tumor. Certainly, if the tumor is at the tail of the pancreas, an operation there to remove it typically is less daunting than one in the head of the pancreas, where that patient may be facing a pancreatoduodenectomy or Whipple procedure. So that might be one differentiator for that particular patient. Also, if patients have specific genetic syndromes, such as von Hippel-Lindau disease or multiple endocrine neoplasia type 1, a small tumor most likely would be watched. Those patients are prone to developing multiple neuroendocrine tumors of the pancreas. And I have many patients that I watch and see periodically every 6 or 12 months for imaging, because those tumors are unlikely to affect the course of their life and impact their survival by themselves. Or on the flip side, doing an operation won't necessarily cure them, since they have a germline mutation that's predisposing them to developing these tumors. So now, what about a tumor that's now approaching 2 centimeters? So at about 2 centimeters, we start to worry that a tumor that is at that size has a higher risk of having associated lymphadenopathy. And you would prefer, and usually typically will recommend for a fit patient to undergo surgery, whether it be a distal pancreatectomy, a Whipple operation, or some of the less common operations that we do, such as a neuroendocrine tumor enucleation, or even something called a central or middle pancreatectomy, where if the tumor is sitting in the neck of the pancreas, you can do a limited resection of that area of the pancreas with clear margins. You can oversew the side on the head of the pancreas and then do an anastomosis or a connection to the tail and body of the pancreas. And that's, again, not a very common operation, but this is a good application. The outcomes, well, for a well-differentiated tumor that's removed, and especially if the lymph nodes are clear, there is a chance of that patient being cured. Once there's lymph nodes, or even if we find liver metastases in those patients, and sometimes we go after this disease even if there are liver metastases, then the word cure is pretty hard to use. So really what we're doing is debulking the tumor in that situation. We're setting the clock back and potentially gaining time, maybe years or even more for patients in that situation. So some of it is going to be very much dependent on the biology of the tumor. In general, we would advocate removing growing tumors, tumors over 2 centimeters in size, and one other class of neuroendocrine tumors that I didn't mention, which are the functional neuroendocrine tumors. These include things like insulinoma, gastrinoma, somatostatinoma, or these tumors that are producing hormones that are obviously going to affect the patient's blood sugar or cause them to have diarrhea or have gastric ulcer formation. And so in that circumstance, removing that tumor can allow that patient to get back to more normal function. And the other syndrome that I forgot to mention, of course, was carcinoid syndrome, which we will occasionally see with metastatic pancreatic neuroendocrine tumors.